Wafa, I could just keep going. Fred, are you seeing these comments?
Oh yeah, I see them all. Yeah, that's
wonderful.
Great.
Yeah, they're just spiraling through.
Yeah, that's fantastic. Really impressive.
All right, guys, so we're going to go ahead and just get started. For those of you joining me for the first time, welcome to Cosi Talks. My name is Cosi Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I am the proud owner of a private practice here that is exclusively for amputees. And I've been working as a physical therapist now for over 17 years. And here with me tonight, very special guest, Dr. Fred Southwick. Dr. Southwick is an award-winning professor of medicine and former chief of infectious disease of the University of Florida. Go Gators. And he is also a graduate of Harvard Business School as an advanced leadership fellow and recent author, right?
Yeah, I've written a few books.
He's written the most recent one being titled Critically Ill, a 5-point plan to cure healthcare delivery. And oh boy, do we need that right about now. So we've got Carol Baker, Dina on board with Fred. Oh, she's just saying hi, Cosi and Fred. Okay. Now, folks, usually we're going to be opening, I like this to be a very interactive show, and we're going to be opening up the floor to questions after the presentation is over. So just asking if you please hold on to your questions, but it doesn't mean you're not going to have the chance to voice your opinion and interact during the show. So stay tuned. Now, usually my show is used to inform, educate, and empower the limb loss community. But tonight I wanted to open this up to the community as a whole, not only to those of you in my amputee audience, but to anyone who's having to stay at home, to anyone who is a healthcare provider that is on the front line, and to anyone looking for credible and accurate answers. So as I mentioned in the video, the previous video, my viewpoint in all of this is that we should respect, but not fear. Because that's where, when we let fear into the situation, that's where we start making mistakes, panic, and chaos coming into the picture. So in my opinion, along with a lot of prayer, I think the best way we can arm ourselves against this is with a lot of good, valid information. So, oh boy, we got more people coming in. My goodness, we got Damon, Robin, William Mays, Ron again. Now, when I do a talk on any given prosthetic foot or leg, I bring on the manufacturers who made the leg or foot. I go straight to the source. And it's the same thing with the coronavirus. I'm doing the exact same thing. I'm going to someone, other way, who is an expert on everything bacterial and viral related. This is the person to get your answers from. And not just because of his decades of experience in the field, but because he knows where to go to get the right numbers, to get the right information, to get the latest studies. So we're going to do a quick poll before we get started. We got Mrs. Mikatinik on board. Whoo, we got the general's wife on board, Dr. Southwick.
Right.
All right. So I know that I've been very frustrated trying to puzzle out from mainstream media and even from the Department of Health the correct and valid information. How many of you out there are frustrated with mainstream media in not knowing who to believe, what to believe, and where to get your information? If you're frustrated, I want you to type in me or frustrated or information in the comments section. Let's just see how many people are experiencing this as well. In the meantime, we've got Theo Chuck and Thea Mary on board. We've got Teresita from Hialeah, Florida. Welcome. We got Herman back on board. Herman, man, it's good to see you. So guys, and Pat on board. So folks, if you guys have been frustrated with everything on mainstream media and not being able to find the information, go ahead and tell me. We got Tracy saying frustrated, Harsh saying me, Mark saying me. Okay. So tonight, we got a lot of people saying me. Grant, that's a lot of frustrated people out there. Dina, Wafa. Tonight, folks, you're going to get answers and you're going to get truth. Okay. So on my show, anybody who's been to my show knows that I always like to know about my special guest story. And Dr. Southwick certainly has a very wonderful story. You and I met 2 years ago?
Yeah, I think 2 years. Yeah, about 2 years ago.
So when I was first opening up my clinic, so I think it's a little serendipitous that as I'm scouring the internet to try to find information, I come across Dr. Southwick's videos that he did on YouTube. And we're going to get to those in just a minute. So I'm going to stop talking because people are tired of listening to me. And I want you to talk a little bit, Dr. Southwick, and tell us a little bit about yourself.
Well, I've been an infectious disease physician since 1980. That's when I got my, I was the chief of infectious disease from 1991 to 2011.
Wow.
And I decided I had done that long enough, so I moved into quality and safety. So I'm a hospitalist now, working in quality and safety, and that's how I ended up writing the book, Critically Ill. But what happened very recently is I just updated the 4th edition of my infectious disease book, Infectious Disease: A Clinical Short Course for McGraw-Hill.
Okay.
And as the book is being in the printer, being printed, this epidemic hit. So my book is not up to date. One of the most important things was missing. So they suggested maybe I'd create some PowerPoints, and I didn't think that would help. So I decided to do 4 videos on how the disease, how it causes disease,
Yep.
how it spreads, what the clinical manifestations are, how you diagnose it, and how you treat it, and how you prevent it.
Yep.
So that's what I did.
And we're going to be covering those 4 videos tonight. So at the end of the show, I'll be posting the links to these 4 videos on YouTube. And as Dr. Southwick just mentioned, we're going to be covering pathogenesis, which means how this virus is created and replicated and gets out there. Then the epidemiology, which how does it spread in the human race? The characteristics, in the clinical characteristics, meaning what does it look like when a patient has coronavirus, and treatment and prevention. Now, folks, some of this information is going to be geared towards our healthcare practitioners in the audience tonight, but all of it is information that we can all benefit from. So, Dr. Southwick, can you start off by telling us the case study that you used in your first video about a young Chinese doctor? I believe her name was Dr. C.C. Jia. It was published in the New York Times. Yes.
Yeah, I was looking. Fortunately, we've only had 1 case in Gainesville so far. So I have 0 clinical experience, and because I'm getting up there in years, it's dangerous for me to actually care for patients, because I have an 8% chance of dying if I get the disease. So I'm working virtually at home. That's one of the reasons I had so much time to do the videos. And what happened is, and this is a big problem in Asia, they have these live animal markets.
Yes.
Where they actually sell the animals live, and then I guess they take them home and slaughter them, or they slaughter them right there in the market. I'm not sure which. But anyway, the point is the market is full of live animals. And this is how SARS started as well, the original SARS. And what happened, and all these viruses, the coronaviruses are broadly infect the animal kingdom. And one of the animals they infect most readily is bats.
Yep.
And bats, it turns out that in the bat, it seems that the coronavirus mutates more readily in the bat than most animals. So it's the perfect mutation machine, so to speak.
Yeah.
And it mutated and then spread to this, the bat spread it to this little animal called a pangolin.
I was wondering how that was pronounced. I was like, pangolin, pangolin?
I think so. I don't know. I've never heard it pronounced, but I think it's pangolin. But anyway, it's a cute little animal, actually. But apparently it's prized for its meat. It's prized for its meat, and they think it has some medicinal characteristics. Who knows? But anyway, that's how it started. And it started in the live animal market, animal and fish market. And it started out as what we call point source outbreak. In other words, just the people that worked in that area got infected. And they started to get symptoms. But then within 10 days, it had spread outside of there and spread very, very quickly. And so the virus, all coronaviruses tend to work the same. They tend to bind to the surface of a human cell or any cell. And we can show this. I don't know. You want to show you show your.
Well, you can show yours. You show your slide, and I'll show mine.
Yours is bigger. You show it. If you hold it up, it'd be bigger than the one I have.
Like I said, folks, I'm real high tech. So just to kind of backtrack just a little bit, there's 7 major human coronaviruses.
Yeah, there's 7 human. 4 are cold viruses, and you can't differentiate them from rhinovirus. They're very benign. In fact, about a third of colds are due to coronaviruses, human coronaviruses. They're very mild. They don't get past the upper respiratory tract. They just give you a cold.
And
you
I
couldn't
think
tell them from rhinovirus.
And I think
and then the other 3.
Uh-huh.
The other 3 are severe. The first was SARS back in 2004, and that also came from a bat and also came from a Chinese live animal market. I've forgotten the animal, but it was anyway. It was another animal, just a pretty rare one. And then and that one was it had a 10% mortality, but it was not very infectious, and I think it only infected a few thousand people, and then it died off, and then it just disappeared. Then in 2013, we heard of MERS, and that was carried, I think it was also bats, but it ended up in camels, and camels then spread it, and it had a 30%, 33, 1 out of 3 people died, but it was even a smaller epidemic. I think it was only 800 or 1,000, so it did not. And it wasn't very infectious. And now this is the third of the coronaviruses, and it's called SARS-CoV-19. And it's called SARS because it's most closely related to the SARS virus, more than any of the others. And they used 19 because it developed in 2019.
Ah, okay. I was wondering about that number, where that 19.
That's where, and then the disease is called called COVID-19. And I think that's coronavirus illness disease, or I don't know, infectious disease. I'm not sure what the D is. Anyway, it's also 2019.
And I think
the reason they picked this, the WHO 5 years ago realized that they did not want to have a locality or relate to an animal, because people would get angry at that country, or that when they had the swine flu, apparently in Egypt, they slaughtered hundreds and hundreds of pigs for no reason because it was called the swine flu. So they've gotten away from all names and all geographic locations, and that's how the COVID-19 name came to be.
And that's good to know, because I think, especially in the beginning, myself included, we were all asking ourselves, why is this so serious? We know it as the common cold. And so this explains. So just again, guys, of the 7 different types of corona, 4 are very minor, common cold, but the other big 3 are the big hitters. So we're going to dig back into my middle school days of learning the life cycle. So I think it's just to me, it's just a little interesting to see how this works. And it also helps to explain why it's as infectious as it is. So here, I got this back.
Yeah, well, the big on the surface of this coronavirus are these little spikes, and you have all seen pictures of it. It's on the news all the time.
Right.
And those spikes are made from an S protein, and that S protein is manufactured by the virus in host cells, and it binds to specific receptors. In this case, that area is where the big mutation was. And what it did is it increased the affinity for ACE2, angiotensin converting enzyme receptor 2, on particularly respiratory epithelial cells. And when they compare its binding to the original SARS, it binds much more tightly. So therefore, when it floats around and gets into the mucosa, it can bind. And once it binds, then its endocytes toast are taken into the cell. That's where there's a replicase that it synthesizes a replicase that then produces the RNA. It's an RNA virus, produces new RNA, and then that new RNA forms into a body right there. And at the same time, the other RNA is used to synthesize the S protein in the endoplasmic reticulum, is where the cell synthesize proteins, and then the little core, RNA core, actually goes into, you see the endoplasmic reticulum actually wraps around it, and the little spikes are then put on the outside, and then it's in a vesicle, and then it is exotized and it's released. And when it's released, it spreads to other cells, and that's when it gets into mucus. And if you cough, it shoots out the virus.
That's where it goes. So guys, just as a recap, because I know I had to look at this a couple of times myself to puzzle it out. So we've got the original virus here with the protein knobs that Dr. Southwick was mentioning. And these little doohickeys, I call them doohickeys, that's really great, right? They look like little field goals, okay? They are the ACE receptors. This is basically a lock and key mechanism. So the virus locks in, turns the key just right, and it can get into the cell. So the difference that what Dr. Southwick just mentioned was this one has a really great ability to lock in and get into the cell more so than the original SARS from 2004, which is what makes it so infectious, okay? So once it's in, it starts doing its replicate, whoops, other side, this way. It starts replicating itself. So on one end, it starts replicating its RNA, right? And on the other side, in the endoplasmic reticulum, y'all remember endoplasmic reticulum from those little cells in science class, 8th grade science class? Okay, so it formed more protein knobs. They come together here, form the new virus, and out it goes, okay? So let me catch up here with my own notes. Now, one of the interesting things is that when it's replicating inside, it doesn't do a very good job of replicating itself, or that it's not proofread very correctly, which is why it mutates so much.
Yeah, a lot of RNA viruses are very inaccurate in their reproduction.
So it's like a fuzzy copy, like a carbon making a photocopy of a
right. Yeah, there's supposed to be a proofreader. Their proofreader isn't as good. DNA viruses are better proofreaders than RNA. HIV is an RNA virus too, and that's why it made so many mutations. And particularly in the bat, it seems that the replicase doesn't work as well. So that's why in the bat. So far, I was very interesting. I heard today on the news that the virus in humans throughout the U.S., we haven't seen big mutations, which is good.
That is good.
It seems to be pretty stable. It seems to be pretty stable in humans.
To treat it. Also makes it easier to treat when it's not mutating.
Makes it easier to create a vaccine that will work.
Right.
Yeah.
So, and we're going to get to that. So as Dr. Southwick said, it starts off in your nasal passages. It starts multiplying there. And during that time, the person is not aware that they're sick. They're not having any symptoms for those first 24 to 48 hours. And as luck would have it, that's when the person is the most contagious. That's when they can spread it all around because they're not aware of it and the high viral load coming out. So we're going to talk a little bit about how this virus works. What is it that makes it so dangerous? Okay, so Dr. Southwick, I'll let you go ahead and take that one.
Yeah, well, what happens after it's in the upper respiratory tract, it moves down into the tracheobronchial tree, into your windpipes, and then it goes out into the smaller bronchi, then into the little air sacs called alveoli. And those air sacs are what exchange oxygen and give oxygen to arterioles. And those arterioles carry the oxygen into your system. And that's how we stay alive. That's how we're oxygenated. We get our oxygen. And what happens is this virus gets into those alveoli. It causes a lot of inflammation. And then fluid leaks into the alveoli. And they fill up with fluid. And then they can't exchange oxygen. And that's, and you see on the CT scans, this ground glass appearance, which is fluid in all the alveoli. And that's when the patient presents with shortness of breath. And then the problem is if it continues on, the walls of the alveoli can get scarred or get fibrosis. And then they are never not able to exchange oxygen and it's permanent.
Yep.
And then you're not going to recover if that happens.
Yep. So there's a couple of questions that just came in. Ashley she says, my random question of the week. My mom and I live together. She is a cancer survivor ×2. I'm a teacher and I have put things in place such as I immediately change clothes when I get home and I've been home for 2 weeks. How worried do I need to be about my mom?
Well, you're not with the children anymore as a teacher?
No. Right now, all the schools have been closed, so I imagine Ashley is also at home.
Yeah, if it's been 2 weeks, you're out of the woods.
There you go. And
Pretty much. The incubation period is 5 days, and the longest has been 14 days. If you're going to get symptoms, you should have them by now.
Okay. And
so
then
I think you're pretty safe.
There you go. Magda says, first, go Gators. Quick question. What is the accuracy with the COVID-19 testing? As the rapid influenza testing usually has a high sensitivity testing of 50 to 70%.
Right. The accuracy as far as specificity, that means do you get false positives or not? You don't. It's a highly accurate. It's about 98 to 99% specificity. Sensitivity is another problem.
Okay.
Because of the way it may be an inadequacy sample, but right now the data, no one's publishing much. I can't find much on it, but it's about 70% sensitivity. In other words, you could have a negative and you still have a 20 to 30% chance you have it.
You have it.
Now, if you do the nasal swab during the early infectious period when the number of viral particles is very, very high, I would predict that the sensitivity would be much better. It might even be 80 or 100%. I don't know. We don't have that data yet. But if you catch, and this is the irony of the whole problem with not having enough tests, they're testing those that are really sick. That's when the virus has gone down into the lung, and actually the upper airway, the number of particles may be very, very low. So you could get a false negative during that period. You want to catch it. The test is most sensitive in the early phases. So it's a real problem. They're testing at the wrong time.
So basically, they'd have to do a bronchoscopy to really make sure.
Well, no, you would never. You wouldn't do that.
That's pretty extreme.
Yeah. You wouldn't do that.
No.
The other thing is the CT scan. It turns out the Chinese looked at this, and it gives a very distinct ground glass appearance that no other virus they've seen ever did. So actually, the sensitivity with a good radiologist is probably for someone that's maybe hospitalized is about 95%, somewhere in there. And specificity is about 95% by the interpretation of the radiologist. Therefore, what I would maintain, and I'm not in charge, but I would want to do a CT scan if I'm thinking of hospitalize a person. I wouldn't need the test because the CT scan is as sensitive and as specific as the PCR, so I don't need it. I need it for the people that are, questioning whether they have symptoms, are going home, and if they are symptomatic, then they're spreading it to their loved ones. So I want to prevent that. I want to make that diagnosis and get them out of the house.
Now, let's talk a little bit about the epidemiology, basically how this virus is spread. And it's primarily, obviously, through the respiratory system, through droplets, specifically from a cough or a sneeze. So basically, the virus can either be inhaled or it can survive on a surface. And we see numbers anywhere from 3 hours to up to 3 days, depending on the surface that it lies upon. And that's actually a question that just came in right now, is how long does the virus live on surface? We've seen all kinds of time frames for everything from cardboard paper to door handles.
Yeah, there was a very recent article, I think 3 days ago, from the New England Journal that looked at this particular COVID-19. There had been studies with SARS and MERS, and there it was 2 to 3 hours up to 9 days. For this one, it's 3 hours and up to 3 days. And it does depend on the surface. Harder surfaces like plastic and stainless steel, it survives longer. Cardboard, cloth doesn't last hardly. It doesn't survive very long at all. So that's in maybe minutes to an hour.
Okay.
So you really don't have to worry that much about letters, cardboard, clothing, cloth, but you do have to worry about when the problem is people touch counters, people cough on counters. So you want to clean your hard surfaces frequently with, I think it's 5 teaspoons per gallon of chlorine, 5 teaspoons of chlorine for a gallon, or maybe it's tablespoons. I think it's tablespoons. Anyway, low percentage chlorine bleach works really well, really well.
Yeah.
And also alcohol, over 60% alcohol works, kills it. This virus and the other way in your hands, washing, the physical act of washing actually can break the virus. Its outer cell wall is fairly fragile. And so, and it's the good news is that compared to norovirus or some of the other viruses that are very hardy and withstand any kind of disinfectant, this one is killed easily. So anything that's approved as a disinfectant will kill this virus.
Great. And then we've got actually Dr. Hogan, he's a radiologist, and he's saying they are showing crazy paving in the lungs, slightly different version of the ground glass.
Yep.
So
yeah, it's really good. I hadn't thought of this before, but the Chinese swear by it. They weren't doing the tests. They were doing CT scans on anybody they thought might have it. That seems a little extreme to me. Radiologists make a lot of money though. But I think if you're deciding on admission, absolutely you want to do that CT scan, and that will give you the diagnosis.
Right there. So let's talk a little bit about the rate of infection. In medicine, they call it subset 0. Am I saying that correctly?
Yeah, that's right.
So the COVID-19 has an R subset 0 of 2 to 2.5, meaning
correct.
One person who is infected can infect up to 2.5 other people. So folks, just for a comparison's sake, it's considered to be highly contagious, but when we compare it to something like the measles has an R subset 0 of 10. Am I correct correct me if
That's the most infectious agent we know of.
So just as a comparison it's still very highly contagious, don't get me wrong, but then we've also dealt with much more serious bugs in the past here in our country. Because a lot of people ask, well, how many people can really be infected by the one person who's walking around the community? Let's see. Okay. So 80 to 85% of the cases of infected people are becoming infected from family members. Is that still the current statistic right now?
Yeah, it's not as clear in the United. We don't have the characteristics of the U.S., but that was China.
Okay.
And I think it's also true of Italy.
And that also other large social gatherings, sporting events, cruise ships. Obviously, we've been seeing that a lot as well.
Cruise ships are an absolute epidemiologic nightmare.
They
have tons. Think of all the surfaces. They have hard rails everywhere.
Yes.
We saw this with norovirus too. And it's just, wow. I don't go on ships.
It's a great eating, but oh man, not during an epidemic, not the place to be. So who gets infected with this virus? The answer is everyone.
Yeah, it's equal opportunity. It gets everybody about the same rate of infection.
Okay, so men equal to women, every age, although young children, and we were having this discussion with my husband, who's a pediatrician, a few minutes earlier, young children often go missed because their symptoms are so minimal and just a little different, So do you want to comment a little bit more on that? We have some viewers definitely in the audience with children.
Well, with children, it can mimic. It's like the other coronaviruses. It just is a little cold, and or a lot of them don't. They may have a low-grade fever. They may not. And we really are. I think there's a study there. We're going to know a lot more very soon. What percentage of kids are totally asymptomatic? What percent have different syndromes? But they almost never get severely ill. It's really, really rare.
Which is a relief for those of us who have children right now, especially when all this started going out. And I just thought, my kids' school, aside from a cruise ship, a school, it's just a breeding ground for, all of these diseases. I know that just the flu epidemic alone, one of my children had 26 kids missing from their grade in a given day from the flu. Wow. So when this started happening, all of us started going, okay, who's been around? Now, as we move on to the clinical characteristics, what does someone look like who has an infection? What are some of their symptoms?
Well, it's there's a giant report in the New England Journal of 1,060 some patients where they broke down the percentages of each of the symptoms, and the three most common are first fever, 98 to 99%, although when they arrive to the hospital, a significant percent don't have fever, but they almost all have a history of feeling like they were feverish. So either we call it subjective fever or true fever. And as the course goes on, they all get fever. So I think the use of one of those little touch thermometer or infrared thermometer is actually a good thing. You will pick up most cases with that. And then the second symptom is cough, a dry cough, and that's probably about 65 to 70%. But there are some that don't have cough. And then the third most common symptom is shortness of breath, but that's more like 35%.
Right.
And that is a worrisome symptom because that means the alveoli are starting to fill with fluid. Yeah. Then headache is fairly common. A new one that's coming out and isn't in the reports, but is coming out in the newspaper is a loss of smell, anosmia.
I saw that. One of the basketball players that was diagnosed mentioned that he had anosmia. Yeah.
And they often do also, they get the headaches. So I think there may be a little bit of a subclinical meningitis, viral meningitis, although I haven't seen any lumbar punctures with it, done. That's the only way you could prove that. But anyway, you tend to feel a little weird. And then the other big one is fatigue. That is very big. A lot of people say, oh, I'm so tired. I'm just so very, very tired. And that Dr. Cosi, that was her major complaint. She just couldn't get up, and she took a nap and she got up and she didn't feel any better. And she got fever, and then she felt short of breath. And those were her main, fatigue and fever were her main symptoms.
Now, what would be the differences between how a person feels with the COVID-19 compared to influenza?
Not a lot different. The other symptom is myalgias. And sore throat isn't described as often in this one, although some people do have sore throat. So influenza often starts with a sore throat. Mm-hmm. They tend to have some rhinitis, some runny nose, and then it goes to the lungs. And they do have severe myalgias and headaches. So we call it's a flu-like illness.
Yeah, there's a reason for that. So Dr. Hogan has an interesting comment. He says, although CT scanning did show many positive COVID cases that were initially test negative, due to the length of time to clean a CT scan and the limited resources, many institutions are not doing CT scans for all persons under investigation. And that is a concern. We've been hearing already about ventilator shortages. So I imagine, shortages all around.
Yeah, I'm surprised by that because it's really easy to clean. And you put a mask on. If you think they're a person under investigation, PUI, that's what that uses. Put a mask on them. And wipe them down. You wipe the areas down where their head was. I think you could use a fairly gentle solution that wouldn't hurt the CT scan. Mm-hmm. I know in China they were doing CT scans for every patient. So I would encourage the CT scan if you're thinking of admission.
Okay. And then we've got, these questions are popping in, so I'm trying to filter through.
When we see the peak,
we're gonna get to that in just a minute.
Okay.
Barbara's question: can this virus be transmitted through normal breathing or only through a cough and sneeze? It's transmitted through the droplets. So
I've heard speaking and singing will create droplets.
Yeah. So, and then Barbara, the reason why they create it can project up to 6 feet, these droplets. So that's why we have that rule for social distancing for 6 feet, mainly because that's about the length of its projection right there. Very good question. Okay, so Dr. Hogan says, I agree, but they're still doing droplet and airborne precautions. So that really limits how the CT scan turnover.
Yeah, well,
Yeah.
The airborne is the only times you really have to worry about airborne is if the patient's intubated, mm-hmm. or you put them on BiPAP or on their very high flow oxygen, those masks. Those conditions do aerosolize. The other thing is really, I think often you see these breathing treatments for asthmatics. Those machines also aerosolize, but otherwise it's just simple droplet. And if the person wears a mask, I think, and you wear a mask, and then you I don't think you need gowns because remember again, it doesn't do well on cloth. You know, I know we want to be perfect in everything we do in infection control, and you could wear. I don't see why the radiologist or the radiology technician couldn't be wearing a gown and a face shield if they wanted to do that. I think that would make sense, and I think a straightforward surgical mask in most cases is really sufficient, unless you're doing one of those procedures that actually creates aerosolization.
Okay, so we've got, and now let's talk a little bit about the testing. So right now, the testing, we already mentioned how its specificity and sensitivity. There was an interesting statistic that you put in this video about for every one person that is tested and diagnosed, there are close to
8 to 9 that haven't been.
That are.
So whatever figure, like in Hillsborough, I understand there are about 90 cases.
That's my county. Yep.
Yeah, 90. So really there are 900. So just multiply by 10, whatever your area has, and that's most likely, and that may be an underestimation because we're not doing testing even on symptomatic patients. It takes forever to get a test.
Yeah.
So it's the big failure is the inability to test. It's just very, very frustrating to all infectious disease doctors.
Let's see. So Magda, the way you can be tested for it is the polymerase chain reaction, the PCR swab test.
Polymerase chain reaction, yes.
Okay. And so it's a swab test, and also, like Dr. Southwick mentioned, CT scan. It's a great method for diagnosis. How long is the turnaround on the swab?
It should be under 24 hours, but
I've been here.
I don't know. They're taking 3 days. There's a new test out by Roche I know about this that takes 2 to 3 hours.
Okay.
So I think we're getting faster. I think their techniques were so ideally you'd like to be able to just wait in the office or wait wherever and find out the result before very quickly. That's the ideal because every hour means you could spread it to somebody else and you don't know. You can't know, unfortunately.
So let's talk. This is the part I don't like to talk about, but it's part of the numbers that are out there, and just to show what's really going on. So average hospitalization for folks who have to be admitted is about 12 days, which is very expensive, just on the economical side, very expensive. Mechanical ventilation, people who need to be intubated, is about 38% of the severe cases.
Right.
And then 80% of the cases diagnosed tend to be the mild to moderate disease cases. But in the critical patients, we do see eventually sometimes the septic shock and then the multi-organ failure and then death. The New England Journal of Medicine, which is kind of like the Bible for medicine for research studies, basically says that the overall mortality, so the overall rate of death of those infected is 1.4%. Is that still an accurate number?
In China, it was 3.4%.
3.4 in China. Yes,
Yeah.
The WHO put out that in China alone it was 3.4, with a range of 0.5 to 3.5% of people dying who were infected. Is that
right? Yeah, it's the fate. What's it called? Anyway, it's the ratio. To determine this, you take the ratio of the died versus the total number of infections.
Correct.
Now the problem is since we're missing probably a huge number.
Yeah.
Probably is 10 times what we said.
Right.
So we're overestimating the mortality. Now, the only problem with that to me is when I'm a doctor, I'm seeing a patient in the hospital. They're symptomatic enough that they had to come to the hospital. So among those that are symptomatic, the mortality is probably 1 to 3%.
Okay.
That's what I want to know. I don't care about the people that have no symptoms at all. That doesn't help me. But it does help me to know this is a serious disease. And when you become severe, the mortality goes up. And if you're critical, they say critical, you've got about a 45% mortality.
And only because this is the best base of comparison for many of us, how does it compare to the mortality from flu?
Well, flu is supposed to be 1%, 0.1%, 0.1%. And this is I think 1 to 3.5%. So it's anywhere from, but some people go as low as 0.5. Okay. So we'll say it's 5 to 35 times more deadly.
Which I'll be the first one to say, a couple of months ago when all of this was going around, I was one of those people saying, well, the flu kills more people than this corona, now we're starting to see, no, I was wrong.
Kill more.
I was wrong.
Yeah.
And unfortunately, in terms of mortality, we are seeing higher death rates in male compared to female. And
yeah, it's about 2.8 versus 1.5, I think, something like that.
And then obviously we're seeing more mortality in people with underlying medical conditions, including high blood pressure, diabetes, cancer, cardiac disease, definitely lung disease, people older than 60 years old. And thankfully the mortality drops for people below 30 years old at this point. So hang on, let me say, I know comments have been coming in and I've been kind of. Shauna asks, how is it true that the virus cannot thrive in the heat? I guess this is also around the rumors that we're hoping with the onset of summer that we'll see a decrease in cases. Is there any validity to that?
People have been very cautious about accepting that. There is some suggestion that hot, humid weather makes it more difficult for it to spread. But there are hot, humid countries where it's thrived. So I think we shouldn't bet on that one.
Okay. Lily Jane asks, has UF Health in Gainesville applied to be a testing provider? If not, why? UF has the equipment.
They are there. They have.
Okay.
This is one of the big problems. 2 months ago, everybody could have, that we've known the primers, what a PCR is, you just take the little primers that would stick to the RNA, the opposite of, you can get the nucleotide sequence, you create these primers, and then all you do is you go back, heat, cool, and it grows, the heat, it separates, grows, cool it down, it grows again. And you just, you can detect like 40, when it's made 40 strands, it becomes easy to see. And so that's all it is. And the hospitals have been doing PCR for over 10 years.
Okay.
They all are experts at PCR. All they needed to do was to take the probes. They all could have developed the test 2 months ago. But the FDA and the CDC prohibited that. This was a major, major mistake, in my estimation. Just tragic. So they were afraid to do it. They couldn't. Now our pathology division has it up and running. I know the Emerging Pathogen Institute at the University of Florida, Glenn Morris, had it running very well, but he wasn't allowed to do it. The FDA and the CDC wouldn't allow him. So he had to create a research protocol. And even that he's had problems with regulators. Outrageous. This is when bureaucracy and wrong-headed regulations can really cause problems. And this really, I think it's going to cost many, many lives.
Tracy has a good question. She says, if someone has COVID-19 and overcomes it, would they be a higher risk for being reinfected, or would they build an immunity?
No, it looks like, we don't know for sure, but I'm quite sure you're going to get good immunity from it. So okay. I think it will protect you.
Okay. Ashley has one more question about her mom, the mom who's a 2-time cancer survivor. She has to have a stent exchange in her kidney in about a week and a half. Should I be worried?
Well, I think you need stents replaced. You really do. You can't wait on that.
Yeah.
For necessary procedures, you take the chance. Where you don't want to be in a waiting room with a lot of people in it. You want to just stay 6 feet away from anybody. Don't be in a small room. The personnel, the students will all be wearing masks because it's a sterile procedure. I think it would be reasonable if you asked for a mask. I think they would give you one.
Right.
So that's what I would do. And wash your hands. Wash your hands. Wash your hands.
Yeah.
When you get out of there, wash your hands.
And I
don't touch anything. Don't touch your face.
I know just the local hospitals in my area, including the one my husband works at, they've been canceling the non-essential and really trying to pare things down as much.
It's now mandated. Actually, you cannot do elective surgery anymore. It's against the law in Florida.
And even just regular appointments. I know a couple of my appointments, I just got a phone call today rescheduling me for June, just pushing it back a couple of months.
Yep. Absolutely.
So
Absolutely.
yes. So let's talk a little bit about, diagnosis. If the best advice now is if you think you are, if you think you have it, if you think you've been exposed to it, is it still best to call your local COVID-19 hotline? Is that still the best?
Yeah, I think so. And they have algorithms to sort of help you. They decide what to do. And then the good news is originally they were restricting all the tests, and only the health department could okay a test. Now, if any physician, if they say that it needs to be done, it will be done, which is good. That was another major holdup for 2 weeks, 3 weeks.
Yep. And folks, the best thing you can do is if you suspect anything, number one, first call your primary care physician. They should be the first phone call that you make, their nurse practitioner. I know they're going to have something set up by now to triage you and send you to the right place. If for whatever reason, or maybe you don't have a primary care physician that is watching you right now, a simple Google search of your local county COVID hotline, and it will direct you to someplace you need to go. So let's talk a little bit about the treatment, because I do see some questions here about the treatment related questions. So we're going to go into that.
Okay, good.
So the primary goal of treatment, guys, is to basically maintain, for the more severe cases, is to maintain the oxygen saturation of the person as close to normal, above 92%, which is not normal, but at least at 92%, while the body fights the virus. Okay. Now, as Dr. Southwick mentioned prior, when the O2 stats start going below 92%, at this point, they're recommending intubation to prevent.
Yeah, we haven't had any cases, but when my reading, I can't say I've had any experience at all because I have not. But the recommendation is intubation. Now, I saw in Italy they had these special sort of closed oxygen systems that may be better, but I haven't seen anything like that in the U.S. So the recommendation, and this is from Up to Date, which is updated literally every 4 or 5 days, every 3 or 4 days. They recommend you do not want to put somebody on BiPAP because that aerosolizes like crazy. You don't want to put them on the high flow oxygen because they're going to get, if they're doing that now, they're going to need to be intubated. And what you try to do is you try to create a positive, we call it a positive end expiratory pressure. You actually, if you breathe, sometimes you breathe with pursed lips, that's PEEP.
Yep.
And people do that. Some people that have problems with the lungs will exhale with pursed lips.
Yep.
So that's what you want to do. You cannot do that effectively without intubating somebody.
Right.
So intubation is the way to go threshold and get them on and get them off as quickly as you can.
And then as of now, for the more severe cases that progress into septic shock or multiple organ failure, the ICU is basically following their standard protocols for providing support.
Right. Just a little cautious with the fluids.
That was an interesting thing, the fluid management, because of the fact that they're already going to be having the inflammation and the fluid in the alveoli.
Yeah, there's some evidence. There's a significant percent. I can't get the data very tightly, but this virus also can weaken the heart and give you what's called a cardiomyopathy, where your heart contractility will go down.
No bueno. No bueno.
So that won't be good for fluids either.
No. So let's talk a little bit about the treatments, because I know that's probably the thing I've gotten the most questions about, and I'll go ahead and address the question that's popped up several times on our feed. We do have some military folks, that my father included, that contracted malaria when they were deployed, and they received chloroquine. Did I pronounce that right? Because I always
chloroquine. That's right.
I always butcher that pronunciation. I don't know why.
Yeah.
And there's been talk in the news about that being a potential. So can you address that particular?
Yeah, I looked up this to find out, and hydrochloroquine and hydroxychloroquine have been proposed for other RNA viruses. They were tested in HIV back in 2006. Oh, this is going to be great. The controlled trials didn't work. Then another big one is Zika. Oh, we'll use it for Zika.
And it
didn't work. Then they tried a dengue. Oh, it's going to work on dengue. Didn't work. These are all RNA viruses, and they didn't work in any of those. And the problem with this disease is patients can suddenly go up or down, deteriorate or get better without any rational reason. And we call that random variation. And what can happen is somebody can start a drug, and then a day later, the patient gets better, and they say, oh, the drug did it. Well, if they hadn't given the drug, it would have improved too.
Right.
And so this is the problem with chance versus specific cause.
Sure.
They see a chance of what's really a random good luck, the patient got better, and they're saying it's due to the drug. So I think these anecdotal cases are a nightmare. They should not be shared. They should not be used. And I love these doctors that have a series of 3 cases, and they're convinced this is the way to go. And over in history, this is proven to be fallacious. And that's why Tony Fauci has really discouraged this. And the problem is we have a president who doesn't have any scientific training. And he's saying this is the greatest thing since sliced bread. And guess what? People are using it. And the thing about hydroxychloroquine, my father took it once for prophylaxis when he went down to Haiti. He had a psychotic break and actually was manic and bipolar for about 5 months after that. And it was definitely due to the hydroxychloroquine. And there's just an editorial in the New York Times by Jesse Gold, who's a psychiatrist at Washington University, pointing this out, that there are a fair number of psychiatric side effects from this drug. And it's similar to mefloquine. Mefloquine used to be used as prophylaxis a lot, but people get such awful nightmares that people are afraid to take it now. And so it's not been used. So the other thing it does is it prolongs the QT interval in an EKG, the time from the QRS to the T wave. And when those are prolonged, you can get arrhythmias and ventricular tachycardia and die. So this is not a benign. If you follow the literature in Europe, for reasons I don't know why, but they had a lot of trouble with Tylenol or acetaminophen overdoses. And so they had a lot of, and that's a horrible overdose, and you get liver necrosis. So they have been pushing ibuprofen in Europe.
So now they're kidding.
So now all their patients, when they get COVID-19, are on ibuprofen. And when they get sick, oh, it's the ibuprofen. So we don't know. The WHO is saying lay off it for now. But I think the problem is that everybody in Europe is on ibuprofen because of this problem. They call it acetamol. I think it's paracetamol is their Tylenol. And paracetamol overdoses were a giant problem in Europe. So they've really discouraged that. And everybody's on ibuprofen. And so that's how France, and this all arose out of France.
And it's interesting because we actually covered that. We did a show on pharmacology a couple months back. And one of the things I really stressed was hunting down the acetaminophen in all of your drugs that you take, because people can accidentally overdose.
Yeah, it's dangerous. But now they're recommending acetaminophen as the antipyretic, the drug to lower the fever and headaches.
And it sounds like they're also recommending not to use corticosteroids because of
steroids. That's pretty firm. Both the WHO and CDC, no corticosteroids. Right. They were shown to be harmful in SIRS and MERS.
Okay, which is interesting because a couple of clinicians, and we won't name names, but they were saying, "Oh, just give steroids to help with inflammation," and I'm like,
doesn't work.
Nope. Okay, so let me just kind of flip through some of these comments, make sure we didn't miss anything. Theo says, "You are incredible for answering these questions, Dr. Southwick." Pam says, "I have asthma and atrial tachycardia. Should I be wearing a mask, presumably in public?"
This mask, this is the problem. We don't have enough masks. So if the public starts buying masks and everybody's wearing masks, then the healthcare providers aren't going to have masks. Now, as the mask supply comes up, honestly, when I've thought about it a lot, I think it's not a bad idea to wear a mask when you're outside, and particularly if you're at risk. But I think you would not, it would not be the right thing to do in our community right now to wear a mask. I think when we get enough masks, if you want to, I think it's it probably, there's no evidence, but you think about it, it's droplet. Somebody coughs, you're wearing a mask, you're going to block it. Now, one argument that's made is you're not supposed to, remember, you're touching the surface and you're not supposed to touch your face. Well, if you have a mask, you'll touch your face to adjust it. So you may actually get more virus on from the fomites, from the hands, but you won't get it from the droplets. So I think the two may actually weigh each other out. You know, they may balance each other out. So it's questionable. There's no data to show it helps. When there are enough masks, I think it would be reasonable to do if it makes you feel better, and it might help a little.
And that'll segue into our next question, which is very interesting because I just heard something about our local fabric stores providing free fabric, which I'm not sure if that's true. But anyways, the question is, Kay asks, what's your opinion on masks that we are sewing with a 0.3 micron filter in between the 2-ply cotton fabrics?
It'll work. It's fine.
There you go.
Yeah.
And
the one problem, what happens if you get the area that'll be contaminated outside of the mask? And so what do you do after you've worn it a while? Yeah. If you touch that, then you could get the virus. So we're having a lot of problems in our hospital, as all hospitals. We're running out of the N95 masks. And we're worried about the supply. And so what we're doing is we're starting to UV treat them. UV light.
Yeah, yep.
Now the problem is UV light, we only have 2 UV light sterilizers. And I just happened to notice I got an email about these new UV lights with little boxes you can put in the box. You know what the UV box, it was only about maybe 1 foot by a half foot, $3,500 for one UV box.
How about the local tanning beds? They got plenty of UV light.
Yeah. But anyway, that's the only issue with the cloth is you're going to carry on the outside the virus.
Yep. Let's see. We've got. All right. Let's move a little bit, guys, into the cornerstones for managing this disease process. And this is where the rubber really meets the road. This is what we can do as individuals in our community, in our society, in our support groups, whatever it is. This is what we can do. So right now, at our disposal, we have 5 basic techniques for preventing this disease. We can do isolation, which is basically anybody who is actively infected is isolated and separated until they are done with their disease. We can quarantine. So anybody who has come into contact with an infected person agrees to stay separated for 14 days. We can do social distancing for those who are over 70 years old, for people who are at the higher risk. We can do social distancing for the entire population. And we can do the closing of schools and universities and businesses. Okay, so those are basically the 5 tools that we have at our disposal right now for preventing the spread of this disease. There's 2 strategies that we can employ, and this is probably where all the fireworks are happening right now in the media and politics, at my own dinner table with my parents this evening. Whether to do suppression, which basically employs all 5 techniques, or to do mitigation, which employs 1, 2, and 4, which is isolation, quarantine, and social distancing of everyone. So obviously in the videos that Dr. Southwick provided, and I don't know if these are going to be updated or not, we can see the curves of the countries where total suppression was done versus mitigation.
Yeah, I actually updated them yesterday, the epidemiology one. I updated it.
So, I mean, from what I remember from those graphs, I know Singapore and Hong Kong.
Singapore and Hong Kong
have
done beautifully. They jumped on it immediately with case finding, quarantine, isolation, and their curves are very flat. I think Singapore might have 1,000 cases total, and very few deaths. In Hong Kong, similarly, And then the other countries that have, quote, flattened the curve, in other words, they were going up at an exponential rate, and now they've flattened, are China and South Korea.
Okay.
And they have both flattened the curve. So it hasn't gone away, but they're not seeing new cases. Not seeing new cases.
And I guess at this point, I know in Florida, they haven't shut us down completely. I think our governor is kind of just day by day looking to see if we're going to go on a complete lockdown, gauging the balance. And that's, I think, just the hardest part. We're not going to, and guys, we're not going to get into the politics because that's not what the show is about. But I think one of the most difficult decisions is how do we balance keeping this at bay and protecting our civilians without completely crashing the economy and everything with the livelihood that people who are currently without jobs right now. So,
well, the Imperial College in England did just a spectacular job at the simulation. And I show that in the videos. And they concluded if we do mitigation, we will overwhelm our health systems. There will be too many people that will they'll be sick. And for the United States, it would exceed early in the wave the number of ICU beds by 35%. And a later wave, about 2 months later, it would exceed it by 200%. So mitigation will not work. The simulations show this very, very clearly. So we really, if we do all 5 things, we stay far below the capacity of the health system. Now, unfortunately, New York is already way past. And what's really interesting, if you don't do anything, and unfortunately, New York didn't know they had a problem, so they didn't do anything early on. The estimate was that for Great Britain, if you did nothing and just let it go, there would be 510,000 deaths in Great Britain, and in the United States, 2.2 million deaths. So we don't know what mitigation. They had a lot of numbers. I couldn't read. There were tables that were too complicated for me, but you will reduce it with mitigation. But actually, suppression is the only way to go. It's the only way to go. So I approve. The schools have closed. Yeah. We're close to suppression. What you have to do, remember, the R sub 0 is 2 to 2.5.
Yep.
The R sub 0 has to get below 1 for the epidemic to go away.
Yep.
And I also looked at a simulation. I didn't include it in the video, but it was from University of Pennsylvania, where I looked at the percent of social distancing, how successful that social distancing was. You have to get 80% of people following it very religiously to get the R sub 0 under 1. If you have 70%, you have 60%, you're not going to get below. And what happens is it's just unbelievable. It just keeps going and going and going and going and going. And they will outstrip the entire health system very, very quickly. I did a simulation for University of Florida, and we would be up to 2,000 beds, by September or October. So we just can't do that. I mean, the only solution is to do all 5 things.
And this is something.
And the irony, the discontinuing April 10th, April 15th, and whatever. Mm-hmm. That'll cost 1 million deaths.
Now, this
is not some theoretical game we're playing. And this is a lot of lives. And look at what happened in Italy. My God, 24% of those over the age of 80 have died when they've gotten this infection. I think they had 750 or 800 deaths today. So we can't play around with this. And this wanting to keep the economy going. Well, you're not going to have an economy if everybody's dying. It's just not going to work. So we have to bite the bullet now. Exactly how long, we don't know. Their simulation was 3 months. That's just ridiculous. I'm hoping not. But then the other thing, once you get it down, then what you do is you open things up and you watch. Right. And you have to monitor if it goes up. And I like the idea of there's an electronic thermometer you can buy that links to your smartphone. Yeah. That links to the internet.
Yeah.
So it's worked very well in influenza. You can pick up exactly where the outbreaks are. The other way is to use ICU beds, the number of ICU beds with COVID-19 in them. And when it gets to a certain threshold, and you have to calculate for every area, then you know you have to go back to the full suppression.
So
that's the only solution. I mean, you can talk about these others, but it's not going to work. Not going to work.
There you have it, folks. I mean, aside from, I know in my household, you know, I've got 4 kids. I've had to close my clinic. I've had to close my clinic. And some of you have seen pictures of my one patient who comes, but it's because I don't have to touch her and she's running. So it's basically my only patient right now. And I know it's a challenge because many of us are losing income over this, but.
Yeah. And the government is passing, I think they're going to pass.
Yes.
A major aid for small business.
Yes.
And they're going to be no interest loans.
Yeah.
And I read a nice little article in the Harvard Gazette about what the Harvard Business School recommends for small business. And what they recommend is you take out those loans and you keep your employees. You support your employees over this time with a small business loan, and you keep your business going. We are going to get over this. It is going to go away, and business will be back to usual.
Yes.
But we've just got to get through this. And the other thing they said is landlords have to forgive the rent for a little while. Banks have to forgive mortgage payments for a little while. We just have to do that. This is nobody's fault. People can't help this. This is just what happens when there's a dangerous infectious disease, and we have a major epidemic, and we have to do the best we can with what we've got, and I think we can do that.
And I think one of the things that's been recalled to my mind, this is the first time in my own lifetime that I've experienced something this. But I just think back to some of my old World War II patients, veterans from World War II, and the disaster that it did to our economy and to England and to all the European nations, and polio.
Right.
Epidemic.
Right. Polio. It's very similar to polio.
And how our country decades back did not have the resources that we have now. And we were able to come out of that. Right. And to me, I'm a big fan of World War II history. So that's probably why I keep referring to it. But just the way how the roles in society changed during the war to keep society moving, and how people adjusted and adapted, and they put aside, well, this is not my job, or this is not mine, or I need this. Or they put it aside to get things moving and to keep it going. And we got out of that. So I think just kind of taking a dose back from those previous generations.
Right. And one of the groups I'm really worried about are the elderly that are shut in and can't get out. They need their support systems and volunteers. And you can do this safely if you're just careful and wash your hands and you keep a distance. You can help the elderly without endangering yourself. And I think that's an essential service that really needs to keep going.
And just even simple things of, I've heard so many people out there, those of us that live near our elderly parents, that, go into the grocery store for them and or elderly neighbors, just small things like that to keep them away from it. So any way we can pitch in. And
the other thing is, I've really felt terrible. Our local restaurants are hurting so badly, and they're all trying to get by. They're offering takeout. Yeah. So what we did for both Friday and Saturday night is we went to our usual restaurants and bought the takeout. And the one restaurant, the woman was just in tears. She said, "Thank you for ordering from our restaurant. We're having such a hard time." So I would recommend everybody go to your favorite restaurants and get takeout if they're offering it, because that will help them going.
The other one I heard is getting the gift cards if you don't want.
Yes, yeah, we're going to do that. Yeah, we haven't done that yet, but I think that's a really good idea. So you're actually, what you're doing is you're giving the small business a little loan, a no interest loan, aren't you?
Yep.
When you buy a gift card.
Yep.
That's a good point.
Little things. And for me, I'm just, as ironic as it is, I'm taking this time, and I'm speaking right now to the parents in the audience. I'm taking this time to enjoy my children. I know that I am constantly, if you're a parent out there, you're going to go, running, soccer practice, music practice, violin, swim team, school, homework from school, sitting down, getting sure bedtimes and everything like that. As ironic as it is, I have been my stress level has actually decreased. So there's something to be said about appreciating the gift behind all of this. And for me, that's been my gift with this craziness and this madness, is the time with my family. So take it for what it's worth, folks, but that's the little pearl that you can find there. So we're going to go ahead and wrap it up with this evening. Dr. Southwick, I cannot thank you enough for coming on here and being in the hot seat for Cosi Talks. I have learned so much from watching your videos and from hearing you talk tonight and helping debunk some of these myths. I know there's many people here who are concerned about their loved ones, have been hearing different things, and to hear it clarified, it's a great comfort. So thank you.
Yeah, I think the more you know, actually, the better you feel. And that's what everybody has told me when they've watched the videos, that they've understood more. It's not, I mean, I'm scared. I am, when I saw this coming, I knew what it was, and people were saying, oh, it's nothing. It's not as bad as the flu. I strongly disagreed, and I told them, don't talk that way. And it's coming. Unfortunately, it's coming true. As everybody in infectious disease has been absolutely terrified by this, and it is terrifying. And I'm worried for all my fellow physicians. I'm worried for the elderly. I'm worried for and the immunocompromised. I saw there was a question about rheumatoid arthritis. So far, I did a little studying, not for COVID-19, but from the update of my book, I tried to look at the literature for the various TNF and other inhibitors, cytokine inhibitors. I can't find much of anything. They really don't seem to, other than tuberculosis, they really don't compromise you that much. So I don't think it's going to be a problem. And one of the debates has been, as far as this alveolar inflammation, maybe we're overreacting. Maybe a little bit of immunosuppression might help. And there is a trial for one IL-6 inhibitor. I forgot, it's a MAB. I wrote it. It's in the videos.
Okay.
But they're thinking that might be good for those that have the full-blown sepsis syndrome, because the IL-6 levels are high. So I think all bets are off with how immunocompromised you have to be for this to be a problem. I don't have an answer, but a mild bit might not be harmful. One other big debate is ACE2 inhibitors. There's the hypertension. A lot of us are on. I'm on a lisinopril. We don't know. I've talked to a lot of people, because it may increase the number of ACE2 receptors. So we don't know, but there's some debate. Maybe I think women have more ACE2 receptors than men, and they're not dying. Men are dying much more. So we don't know. We don't know. It's all up in the air. It's all up in the air on that.
All right. So the basics go, folks. If you feel like you've been exposed, if you feel like you're having symptoms, call your doctor, call your primary doctor, follow their directions, and then call your COVID hotline. And for those of you who are getting tested or whatever, for those of you who have the mild to moderate symptoms and are being told to stay at home to manage your disease there, make sure you're in contact with your doctor as the day-to-day progression goes. Okay, folks, I know we had a lot of questions here tonight, and there's some of them that I know I probably missed, and it was on accident. If you have any questions that I missed, please feel free to send me a message through my Cosi Talks Facebook Messenger, and I will be sure to get an answer back to you. And guys, I'm going to be posting, after I finish this post, I'll be putting the information to Dr. Southwick's YouTube channels. There's 2 of them. Yeah,
it's the one with the South F at EPI is the one.
Okay. I'll be sure.
That's the one where I'm actually moving all my medicine stuff over there.
Okay. So
I'm going to leave the quality and safety on the other one.
Got it. Because I've
updated. I'll send you the link to the epidemiology one, and I just updated the little guideline for everybody. I didn't have the 6 feet limit in the original one. I put that in there. So that's a 2-minute video that I would recommend share with all families, friends. It's just a really crisp little video that just tells you everything you need to do.
And I got to say, folks, the videos that Dr. Southwick made are very easy to understand, very well laid out, very well explained. Graphics, I'm impressed. Whoever you're using for your graphics person, I
know it's a company called Vyond, Vyond.
Very nice.
I pay a certain amount a year, to be able to access their animation.
Very nicely done. So folks,
it works well.
If you're on my email list, you'll be receiving these links directly in the next e-blast. If you're not on my email list, you need to get on it. You can go to cositalks.com and you can sign up through there. And this video, I'm also going to be putting it on my YouTube channel under Cosi Talks. So if you don't mind, while you're on YouTube looking at Dr. Southwick's videos, show my channel some love. All right, guys. We're going to close it up for this.
Okay.
Thank you. Thank you.
All right. Thank you.
God bless and take care and wash your hands.